One thing that I love, and this is, I think, my favorite word in chiropractic is congruency. And everything that you do philosophically, what your belief system is, how you practice chiropractic. So the application of that philosophy and your belief system in your practice, for you to be successful, there has to be congruency in that. And that's why when we talk today, we're going to talk about adding corrective care protocols to your technique, to your therapies, to your education, to your care plans, your processes. That adds an element of congruency to what you're delivering. So if you're truly trying to correct subluxation and help people to understand that chiropractic is not about treating symptoms, it's about removing interference, correcting subluxation, allowing the nervous system to function better, and allowing that innate intelligence, the energy, the life that's within the body to flourish at its highest level with no interference, then having a technique and the systems to relay that to the patient and get predictable outcomes is really important. And for those people that have implemented that, you've seen the value in doing that in your practice because it takes your patient education to a different level. All right, so this is all about integrating corrective care into your chiropractic practice. So how are we going to do this? Well, there we go. The whole purpose, and this is why, as I introduce this talk, we talk about corrective and structural care and how that adds this element of congruency, because corrective care is really the most congruent way to deliver the philosophy of chiropractic. In my opinion, this is the best way because it comes from a scientific, it's predictable, so there's a predictable outcome to achieve better patient outcome and results. And that's really why I love corrective care. And implementing it, even if you don't do anything now, you can do subtle little things to implement corrective strategies that are going to add value and elements of better results to your practice. So here we go. So starting right from the assessment and the intake. So obviously, when we see a new patient that comes in, we do a comprehensive history. We talk about lifestyle and postural habits. It's so vital to find the hot button. And we talk about this all the time because keep in mind, patients are coming to see you not because they have a pain. Let's really, really understand this. Patients don't see you because they have pain. They come to you because that pain is affecting their life in some way. It's stopping them from doing something. It's a limitation of really what they're trying to achieve in their life. And they might not even realize that, but that is the underlying problem. So let's try to figure out what that underlying problem is and making that connection, finding out from that patient how this symptom is affecting their lifestyle is so vital to communicate or to build rapport and build trust. It's so vital. So once you find that, then we can start to educate them about the root cause. This is all about the root cause. So not necessarily spending a lot of time talking about the symptoms. And let's digress a little bit because realize that if it was just the symptom, if they just wanted to get rid of the pain, most people would just go and take a pill. Like that's the easiest and cheapest and fastest way to get rid of symptoms. But there's an element of people don't just want that. They want something greater than that. And they might not realize it or be able to verbalize it or really understand that. But as long as you understand that, you make a better connection with them. So once you know that, you start to educate about subluxation and nervous system. So knowing that day one script, if you're doing any element of corrective care, knowing your day one script and being able to help them to understand what really truly is a subluxation. That is so vital. So knowing that script forwards and backwards, that there is this amazing healing power in your body that runs from the brain through the nerves and out through all those peripheral nerves to every single cell, tissue, and organ in the body. And when there is subluxation, there's interference, there's disconnection from the life that flows from the brain to the body. And when you can explain that articulately to somebody, they get it. And now, if you have a system to relate the alignment and the structure of the spine, and how when you lose that normal structure, it adds to the progression of subluxation and the degeneration that happens, which therefore affects the neurological function, which therefore affects the potential for them to reach their God-given potential in life. And if they can get that, you have changed their world. Like that is so vital right off the start. So then, to be congruent, your examination needs to be consistent with that message. So the structural neuromuscular exam. So remember, here's the thing. If you're trying to correct subluxations, if you're educating patients on subluxation, and you're still doing orthopedic testing, which really identifies pain. That's really what orthopedic testing does. It identifies limitations of soft tissue, it identifies limitations of joint motion. It is all about symptoms. We really need to get away from that. So putting the proper examination techniques into your system again adds an element of congruency. So range of motion tests, postural pictures, leg lengths, bilateral scales, neurological scans, x-ray views, these are all tied to subluxation detection. So whatever tests you use, make sure they're congruent. And here's the thing, I would even go so far as to say, make sure the tests that you're using in your exam are measurable. So doing some level of measurable test that you can take a baseline measurement and then use that measurement down the road in your reexamination, that is absolutely vital. It just helps you to take that patient's mind off of the pain and onto a level of correction. Okay. All tied to subluxation detection. And then when we can compare any of our testing and the imaging to baseline objective measurements, I'm going to get into this in a little bit. So having normal pictures to show the patient what a normal looks like compared to what they look like is so powerful. So corrective care versus symptom care. Well, remember, symptom care is all about relief of pain. It's about removing the symptoms. It's always short duration and you're always going to get drop off. So if you're having patients not finishing their care plans or dropping off through the course of care, it's only because they didn't get it. You failed, your office failed to help them to understand the importance of full correction. So if everybody knew what we knew as far as how important it is to have subluxation correction and how that affects the body's ability to adapt to its environment and heal and reach its full potential, everybody would be lining up to come to your office from the time that they start care to for the rest of their life. So making sure that those systems are in place to educate those people are again really important. When we get into corrective care, we help sustain that level of education. So it's about structural alignment, posture, prevention of degeneration, and the most important thing is relaying all that to neurological adaptation. And this is where, Brian and I talk about this all the time. We can get so caught up in correction that we become mechanics. We become corrective mechanics. We always need to remember that the purpose of the correction is to restore proper nervous system function. So therefore the body can adapt. And that's what's really most important. The body has to be able to adapt. And that's why we do the correction. So it's really important, obviously, to restore curves and pelvic leveling and, improve scoliosis. But as long as the translation of communication is all about, we do that because we want to remove stress from the nervous system. So the body can therefore adapt and heal at a higher level. That's what it's all about. So that when we're talking about subluxation and correction, we have to bring up nervous system adaptation. Okay, that's again, make sure that's in your communication. It always requires objective measurements. It requires commitment from the patients, and obviously it's a phased approach. So when we talk about patient education and onboarding the patient, obviously we're showing patients their structural deficits. So we're showing them their x-rays, we show them their neurological scans, we show them their posture photos, whatever testing you're doing. And like I said, it's always really important to compare those to normal pictures. So you can show the patient their test versus this is what's normal. That is the most powerful thing that you can do. When patients can see that they are lacking in some way, that they are not normal, or that their body's breaking down compared to what's supposed to be normal, that is again very powerful. It's a powerful motivating factor to get that patient to commit to care. So compare those normals. And educate the progressive nature of subluxation. There's a great study, and I used this for years, by Tapio Vitamin. You can look it up. I can send you the details if you want, in the Journal of Clinical Kinesiology, 1987, where he said that when the spine is subluxated, and I'm paraphrasing because he used a lot of scientific medical terms, not the term subluxation, but when there's fixations of the spine, when the spine is out of place, there's a degenerative factor that happens that there is actually radiological evidence. So evidence on x-rays that that spine degenerates within 6 to 12 days. So when there is some level of injury, misalignment, abnormal motion, abnormal position of that spine in that study, it says within 6 to 12 days, that spine starts to degenerate and it's seen on x-ray. That's, I mean, that is enough for me to say, hey, it's worth getting your spine checked weekly or at least bi-weekly so you're staying ahead of that. Because if you don't, your subluxations are progressing. And that was part of our doctor's report. That was part of my one-on-one communication and the reported findings. That was a day-to-day chiropractic table talk type of message. People needed to understand that. It was a motivating factor to make sure that they stayed under care for the long term. So explain the phases of care and obviously the expectations. This is not a quick fix. The farmer doesn't plant the seed and expect to reap the harvest tomorrow. There has to be a nurturing stage. There has to be commitment. So stress the investment of time, compliance, and obviously the home effort. And I mean, you guys use the analogies of braces or strength training. You don't start at the gym and in a week you're going into the bodybuilding competition. It takes time for the body to adapt. The comparison of braces at the orthodontist was always a really good one. People understood that. And the big question was, after the braces, everybody seems to know whether they had braces or not. What do you have to wear? Well, you have to wear a retainer. And if you don't wear the retainer, what happens? Well, the teeth go back. Everybody knows that. Everybody that I've asked that question to answers that question correctly. They know that. So it's the same analogy with chiropractic care. If they quit chiropractic care, does the spine stay in its corrective state or does it go back to a subluxated state? Well, people just naturally understand that analogy. So this was a great posture picture. So if you're doing any type of posture analysis where you're maybe taking a picture and you can show the patient this postural analysis and show them their picture. And this is only valuable if you can show them their picture. So showing them this picture is one thing, but if you can compare their picture to these pictures, all of a sudden it has more meaning. So that's where these tools become very, very valuable, showing them normal and then showing them the different phases of postural change. So here's the thing. So for those of us who are perhaps not taking x-rays, this is a fantastic tool to help patients to understand the importance of posture and how it affects the spine, the alignment of the spine, and therefore the neurological adaptation. So if you're not taking x-rays, this is the next best tool to show them that. And then you can compare these posture pictures to actual x-ray or MRI pictures, which I'll show you in a few minutes, and patients understand it. They get it. So when we start talking about obviously care plans, there's really, I've seen so many different variations of care plans. It's got to be something that you have confidence with, but it's never short term and it has to be intensive. So any time that you're trying to get correction in the spine, there has to be some level of intensive care. So typically it's 2 to 4 times a week at least for the first 4 to 12 weeks. For those of you who right now are at Dr. Tony's office, I mean, you're probably getting adjusted 3 or 4 times a day. You're spending 6 hours in his office every day because there has to be that intensity. So in your office, those patients need to expect to be there at least 3, maybe 4 times a week, maybe daily for a period of at least 4 to 12 weeks. We always did a 3-time for 12-week initial intensive care. And then their progression or their advancement into the next stage of care, where they would graduate to just a 2-time a week or a 1-time a week, was not ever based on symptoms. It was only based on correction. If they were getting correction, they would advance. If they didn't get correction, they would either stay on this intensive care plan or maybe even we would up the intensive care plan. If they were coming 3 times a week, maybe they needed to come 4 or 5 times a week. If they were coming once a week, they may need to come 2 or 3 times a week. So that was always based on the results that we were trying to achieve. And then, of course, the second stage, the stabilization rehabilitative stage, is 1 to 2 times a week for a period of time. And then maintenance or wellness. I always liked weekly based on that study that I just talked about, the clinical kinesiology study. 1 time a week, for a lifetime. Sometimes people would graduate to once every 2 weeks. We rarely had people go once a month unless it was their own choice to do that. But I just found that going once, and I would always compare it to say, listen, if you were going to get a gym membership, how much benefit do you think you'd get by going to the gym once a month? I mean, better than nothing, of course, but obviously it has to be a little more intense than that. And that would be enough to get people to jump onto a weekly or biweekly plan. And remember, correction, here's the thing. If you've ever had a surgery, I just had a brother-in-law who had bilateral knee replacements. Any type of damage to the tissues, connective tissues, especially in the spine where you have annular tissue of the disc, every surgeon, every orthopedic surgeon, every medical professional that deals in that type of rehabilitation will always tell you 12 to 18 months for rehabilitation of those tissues, for healing of those tissues. It's the same thing. Don't be afraid to tell your patients this is going to take 12 to 18 months to repair. Neurological tissue, once we start to get the interference and pressure off that nerve tissue, it takes time to repair. I can tell you that firsthand when I had my neck injury. Four broken vertebrae, one was completely shattered, and I had severe neurological deficit, and it went on for more than a year. And I thought it would never go away, but it took probably 12 to 14 months for those symptoms to finally, the numbness and tingling to finally dissipate and finally go away. So taper the visits only as the objective improvements are documented, not as the symptoms change. If you start changing the visits, or if somebody says, "Hey, I'm feeling a lot better," and your first response is say, "Okay, well, let's drop you down to once a week instead of 2 times a week," you have just lost that patient. You have just demeaned anything that you've tried to educate them to. So the answer really should be, hey, let's follow through with this plan until your next re-exam. We'll reevaluate, or maybe put in a new re-exam to double check. But before you change the frequency of care, make sure that there's a re-examination to substantiate what you're telling the patient. That is, again, really important when you're trying to maintain congruency in your communication and your technique. Okay. So use those re-exams to guide the phase transitions. So home care. I mean, home care rehab. I mean, this is for you guys that are not doing some level of home care. Just honestly, just put something in. Put something in, and literally every single patient in your office should be doing something. Maybe they're not getting a full home care kit and doing head weights and Cerviguard and um, you know home traction and wobbling and whatever else is in there. But they could at least do some level of sleep rolls or fulcrums. They could at least do maybe even a wobble disc at home to do something, but get them engaged in something, because not only will that help them progress in their corrective changes, but it gets them engaged in the care. And people that are engaged in the care are far less likely to drop off. That is where it gets really, really helpful. So it's really essential to long-term success, and it turns the in-office gains into lasting change. Not to mention, adding home care is another stream of income. It's an extra added income to your office. So it can be a really valuable tool for predictable results, but it helps you make a little more passive income as well. And it keeps patients responsible for their own progression. So when patients are partially responsible for their improvement, when they're not getting better, that was always the first question I ask, is that how often are you doing your home care? How often are you doing your tractioning? How often are you using the sleep rolls? How often are you doing the wobbling? How often are you wearing your head weights? And ultimately the answer was, well, I dropped off. And so no wonder they're not getting better. And I would say like that, well, no wonder you're not getting better. So, it was kind of a kind and compassionate way to say, hey, listen, you got to be engaged to get the results. So it takes the total onus off me. It becomes a team effort and helps them get re-engaged. So get doing some level of home care for every single person in your office. So remember, obviously, there's lots of different ways to do this. There's obviously the head, shoulder, hip weights. There's the wobble chair exercises. There's traction units, cervical lumbar traction units. There's the Cerviguard bracing, vibration plates, foam fulcrums, positional supports. But at least get them doing something. There's all kinds of different ways to do that. And for those of you who don't have some level of therapy in your office, you have to put something in. And I mean, even if you're just dipping your toe in the pool, get some wobble cushions and put them on your waiting chair seats or your hot seats, because it turns your waiting room. Think about this. When you think about a medical office, a chiropractic office, you see a bunch of chairs there with nothing on it, then that becomes a waiting room. And waiting rooms are boring, they're low energy. But if you can turn your waiting room into a correction area, all of a sudden people are engaged. They're engaged in their correction. It's new. When a new person comes in and sees all this happening, it's something different. It sets you apart. It makes your office unique. And somebody that comes in, when they see a unique office, it adds value. they all of a sudden put you in a different perspective than all the other chiropractors in your area, all the other physiotherapists, all the other massage therapists, medical doctors. You become very different. So even doing that, wobble discs, some wall traction units, all of a sudden your office looks incredibly unique to the new people. Re-exams. Okay, so when you're doing any type of corrective care, the re-exam protocol is always absolutely necessary and it has to be done properly. So, because the re-exams, not only do they give you an objective assessment for how that patient is coming along, so that then you can relay that objective assessment to the patient to show them, hey, you may still be in pain, but you can see objectively your curve is improving, your neurological scan's improving, your posture's improving, bilateral scales, these are all improving. So you give them hope, number one, or contrarily, the patient might be feeling better, but they still have an alordotic spine on X-ray. Their nervous system scans are still very colorful. Their bilateral scales are still 15 pounds heavier on the right side. So then you can have some leverage to say, hey, listen, I'm glad you're feeling better, but you're not corrected yet. So it gives you leverage to be able to influence that patient to make sure that they're staying under care. The whole purpose of re-exams is to recommit the patient. And I'm going to say it's more to recommit the patient to their care than it is to monitor the results and their progress. So think about that when you're doing the re-exams, and that's where it becomes so important. Our mindset, and we trained on this as a team, was every single person, when it came to the re-exam time, had a foot out the door. And not to sound negative or pessimistic, but we took it that seriously that they were ready to leave and we had to recommit them to their care. So that's why we trained on re-exams so regularly to make sure that we were excellent at it all the time. So first re-exam should be no more than 4 weeks or 12 visits into their care. In fact, I would say if the majority of your new patients are not making it to that 4-week mark or the 12 visit mark, you need to get your re-exams done earlier. So maybe it's at 3 weeks or 8 visits or even 2 weeks and 6 visits, whatever that might be, to make sure that you're recommitting those patients earlier. So, and obviously you perform your objective testing during that re-exam, recommit the patient. So very simple. And I'm going to share these pictures with everybody, that it's really important to make sure that you have the evidence, the normal comparative pictures, and the pictures of subluxation so that the patient can compare their results to what they see in your office. And these should be very visible in your new patient exam area, your consultation area. Whenever you're talking to the patient about their results, have the normal pictures handy so that they can see where they line up. So obviously a normal neck x-ray, lateral cervical curve, and we know scientifically that it's been shown that at 43 to 45 degrees in lateral cervical curvature, there's the least amount of stress on that spinal cord. So if you have an MRI view or a sagittal dissection view, you can show them when somebody has a nice smooth cervical curve, good disc spacing, no or very minimal degeneration, that spinal cord has a nice thick pathway to travel from the brainstem, from the brainstem, down through that spinal canal, down to the rest of the body. And that was, whenever I talked about correction, I always had these pictures handy to make sure that I was explaining that and showing them this is why we want to get that curve back in your neck. So if you're only at 15 degrees or 20 degrees in your lateral cervical spine, why do you still need to come in 3 times a week? You're not corrected. And this is why. Because if you're only at a alordotic spine, you've got less than that 43-degree curve, your spine's going to look like this. Your spinal cord is being stretched. There's some level of compression. Even though there's no degeneration at this point, this brain cannot communicate to the body effectively and properly. You're only at a certain percentage of function and healing. You can't reach your God-given potential if your spine is in a position like this. You just can't. Your kids cannot reach their God-given potential if they have a spine like this. And this would be the conversation all the time. So does that give me leverage to say, okay, let's get your 2 kids in to get checked? They haven't been in to get checked yet. Let's get them in to get checked. And this is all part of just growing your practice, if you can be so committed to this. And then you can show them if there's degeneration, and you can show them their x-rays and compare their x-rays and show them some disc degeneration or osteophytes. Well, what does that do to the spinal cord? Well, you can see that those discs are bulging in. There's osteophytes and there's disc tissue that's actually bulging into that spinal cord. Well, how is the body functioning? How is your heart functioning? How are your kidneys functioning? How's your liver functioning? Oh, did I strike a nerve when I said kidney function? Oh, yeah, by the way, you have to do dialysis 3 days a week. Well, guess why? So these are all things that patients need to understand. And again, when you communicate this properly, it gives you leverage. So have these pictures handy. In fact, we used to have them laminated, and we had a like a binder ring around them, and I could flip the pictures and go to every phase, and they were at every single adjusting table. So I had access to them everywhere in the office that I could explain to anybody at any time what was going on if they had a question about why they were coming in so often or why they needed to continue under care. And then, of course, obviously, phase three, you have your phase three picture and your spinal cord with severe degeneration. That's like a crooked country road. In fact, I would often start singing just to joke around the country road song from John Denver, because that's what your spinal cord looks like. It's like the country road. So you're not making it home this time on this country road because there's no messages getting from the brain to the body. They're getting totally disrupted. So this is why you need to be under care for the long term, for your lifetime. And then obviously phase four, we don't have too many patients in phase four because I would often ask them, so if somebody in phase four, where are most of them now? Well, they're under the ground. They're dead. So because they've lost all their function. So this having these pictures gives you incredible leverage and power to be able to communicate with that patient and create urgency and help them to understand why they need regular care. And then obviously to have a picture where you can show them a correction. So this is somebody who came in with a straight neck, only 12.9 degrees, and after 12 weeks of care, this was their re-X-ray, and we got them up to 30.6 degrees. So this is to give them hope, where you start to show them that this is exactly why you need to stay in here 3 times a week, and you need to do your home care, and you need to do your wall tractioning and wobbling when you come into the office. So doing these things is, again, very, very important. So, guys, I hope that's helpful. And I think even if you're, whether you're an expert at spinal correction now or whether you're just dipping your toe in the pool, there's always areas to improve. But I think the most important thing in all of this is helping patients understand why they're there. Use spinal correction as a tool for communication to help them to understand the principle of chiropractic, because this is as I said earlier, the most congruent way that you can deliver the principle of chiropractic to people is this corrective care model. It just helps them get it. They just get it. And then you can monitor it, and it takes the symptomatic effects totally out the window as far as the decision for chiropractic care. So start doing some level of correction, improve what you're talking about. Hope that helps.